In medicine and social accountability in the global context. Our speaker is Dr. Bruce Reeder, who is a graduate of our College of Medicine from 1976. Bruce has spent the last 3 decades committing himself to the field of community health and epidemiology. He's applied his knowledge internationally through Doctors Without Borders, including in Liberia during the Ebola virus disease outbreak. Currently, Dr. Reeder is Professor Emeritus at the University of Saskatchewan, and he also co-chairs the U of S One Health initiative. Dr. Reeder.
Thank you very much, Ayub. I wish to thank the committee for inviting me to give the Gertler lecture. It's indeed an honor. As I understand, the lectureship was set up to identify and bring speakers to Saskatoon that could address key strategic issues and directions for the College of Medicine. And I'm pleased to say that social accountability, as I'll outline, has been an important direction for the College of Medicine here. And in fact, the University of Saskatchewan College is leading in the country in this dimension. And I will give several examples that are really a credit to this institution. So to begin with, like many of the speakers, I have no commercial support or conflicts of interest in this presentation. So in the remarks that I'll give, I will outline first the concept of social accountability, look at its relationship with humanitarianism, and then identify activities that can be undertaken by medical professionals both here at home, but especially abroad in this field. So what is this social accountability? As we were just discussing at the break, it's really in the last 10 to 15 years that this has become more part of our parlance in medical circles. But indeed, some of the concepts do predate that considerably. If you look for definitions, 2 dimensions to this concept of social accountability are important. One is responsibility, the other accountability. So responsibility is the fulfillment of obligations that are attached to a particular role, whereas accountability is the obligation to account for one's conduct. Now, these are 2 dimensions that we'll talk of, but we'll, through the course of this discussion, really use the term accountability to represent both of those dimensions. So the World Bank has used this terminology for at least 10 years, if not more, and this is in respect to governance. For example, they consider social accountability to be the extent and capacity of citizens to hold state service providers accountable and make them responsive to the needs of citizens and beneficiaries. Interestingly, too, the concept of corporate social responsibility has gained some traction in the last several decades, and there is an accreditation available in the area of social accountability as a result of agreements between major corporate and civil society actors. So this accreditation called SA, Social Accountability 8000, has 2 components. It's a auditable certification that encourages corporations to develop, maintain, and apply socially acceptable practices in the workplace. And these acceptable practices are listed below, but include the regulations around child labor, compulsory labor, health and safety, discrimination, remuneration, working conditions, and corporations who in their supply chain wish to have certification for social accountability need to be accredited and meet these standards. So like you, I find this very attractive. It's in a bit like free trade certification for products. Social accountability accreditation gives the consumer some assurance of good work conditions and practices in the factories in the supply chain of these corporations. So the idea of social accountability has been extends quite broadly from corporate to political, and as we'll see, into professional circles. So in general, responsibility then is the obligations of an organization or profession to the society, the responsibility to react, and accountability is being held accountable for the actions undertaken. As they apply to health and social professions, this, again, if you stand back a bit, is not new to the medical profession. Social responsibility is the fulfillment of obligations that are attached to the role of physicians, whereas accountability is our obligation to account to society for our conduct as a physician. The World Health Organization in 1995 convened a series of meetings that resulted in a statement on social accountability for medical schools and the medical profession. And Health Canada followed that up some years later in 2001 with our own statement on this concept as it relates to medical education. And so the definition here, I think, saw yesterday in several of the presentations. Medical schools have an obligation to direct their education, research, and service activities toward addressing the priority health concerns of the community, region, or nation they have a mandate to serve. And the important here, the priority health concerns are to be identified by governments, healthcare organizations, health professionals, and the public. So we will see and focus most of the time in this talk on the obligations of the health professions, medical profession in particular. But indeed, this idea of social accountability applies, I think, as Dr. Gelman mentioned, to citizens. That is, what do we as citizens have as a social accountability to our society here in Canada or abroad? What are the obligations of governments, both governments here in terms of development support and governments abroad to social accountability to their populations? So for physicians, well, to whom are we accountable? Well, certainly we're accountable to patients, and that really is the foundational relationship in medicine. But as we'll see, it's generally agreed that we have responsibility and accountability beyond that to the community, and this could be seen as the community in which we practice, the local community of our patients and their families, to broader society, and that could be our national society, but global society as well. And as a profession, we have obligations also to the profession itself. So in what form would we see social accountability, or do we see it? Well, the concept is, if you trace it back, not new. Rudolf Virchow, a German physician in the 19th century, identified concepts, I think, again, referred to yesterday, that really are the harbingers of social accountability. The physician's oath, which originated with Hippocrates' oath and was remodeled more recently, and the Code of Ethics of the Canadian Medical Association show the integration of this concept quite broadly in our field. Virchow, for example, over 150 years ago, identified medicine as a social science, and politics is nothing more than medicine writ large. And if medicine is to fulfill her task, she must enter the political and social life. Physicians are natural attorneys of the poor, and the social problems should largely be solved by them. So even then, suggesting physicians have a role to address these societal issues, including health issues. The physician's oath agreed to by the World Medical Association following the Second World War give voice to this as well. I've extracted two of the comments. I solemnly pledge myself to consecrate my life to the service of humanity, indicating a broader commitment than simply to one's patient. The Code of Ethics of the CMA in the 2004 version identifies the need for physicians to recognize the origins of health and disease in our society, if you like, the social determinants of health, and recognize the profession's responsibility to society in matters relating to public health, environmental protection, legislation affecting the health or well-being of the community. So clearly, fairly strong direction from early times and up to the present, including our medical association. Indeed, medicine and the practice of medicine is clearly a social contract between the profession and the practitioners and society at large. We are, like other professions, self-regulating. That gives us responsibility, but clearly also accountability. More recently, the development of what are called the CanMeds roles have been originally proposed by the Royal College of Physicians and Surgeons, and the College of Family Physicians of Canada have similarly adopted these 8 dimensions of medical practice, 2 of which are clearly related to social accountability, that of advocate, that is advocating not only for our patient, but advocating for social change and action, and also the professional responsibilities. Over 10 years ago now, the Future of Medical Education in Canada, both the undergraduate committee and then subsequently the postgraduate committee, identified, especially the postgraduate committee, the specific need to improve training and action on social accountability for medical students and residents. And we'll discuss that a bit more in a minute, but that includes addressing priority health needs of communities, diversifying learning contexts so that residents and medical students have exposure outside of the tertiary care institutions and have exposure to underserved populations, and the enhanced promotion of prevention and public health. So both the WHO and Health Canada document have provided, I think, a nice framework for thinking about socially accountable health care. And they have identified 4 dimensions that we need to consider. Is the health care relevant to the priority health needs of the population? Is it high quality? That is it effective? Is it cost effective, the best use of funds? Is it equitable? And intrinsic but not explicit in the documents also is the healthcare sustainable? And we spend quite a bit of time in Canada thinking about sustainability of our healthcare system, but indeed this is an issue in healthcare around the world. We just were speaking of the HIV programs in sub-Saharan Africa. Well, it may be in jeopardy and not sustainable if major donor funding is withheld. So we need, as we intervene and help abroad, we need to think of building sustainable capacity. So these, we'll come back to, they're quite useful dimensions. So for medical schools, what are the implications? Well, education, a main focus clearly of medical schools, in the area of content, we need to ensure that the content is socially engaging. There is clearly an important role for basic science and understanding the clinical dimensions of medicine, but it could be argued that we need, and here I would say at the U of S, are increasingly emphasizing the social role of physicians as well as the clinical and scientific role. Service learning needs to be enhanced. This term is used now more frequently. That means contributing in a real way in populations that are priority populations for the country, for the province. And faculty need to move along with students in this regard. As with many issues in medicine, as it evolves, the faculty need to at least be up to speed with the students, if not one step ahead. So we need to put energy into faculty development around social accountability. And now this is being incorporated into accreditation standards, and we know that too will drive change in the curriculum. In the area of research for medical schools, the assessment of impact of social accountability needs more attention. It's not quite clear how we measure social accountability in the real world. How do we know if we're doing socially accountable practice, or if our interventions and projects meet a certain standard? It's important, as we've just talked of, that the research that we do engages the community, or the community is, if not the leader, at least a full partner in such research. Dr. Skinner was just talking of the partnership, actually an extraordinary partnership that he's developed, and he and his team with the First Nations community. That certainly applies to clinical care, but also to research. I think so in medical school research and medical research more generally, we need to find the right balance between this focus on community, socially accountable research and basic science research. There's no simple answer. It will vary from institution to institution, but the prominence of this type of community-engaged research needs to improve. Finally, in service, the implication, as we earlier mentioned, is that diverse practice settings are needed to expose students to underserved populations, to innovative approaches, effective approaches, and relevant approaches to the problems faced that we would think have been weak on having feedback or account of the water supply here. This is the measles vaccination with, of course, several thousand children vaccinated. The Ebola virus disease, we all know, was a catastrophe. It was not discovered early. First case in December, not really brought to the awareness of clinicians or WHO until about March of 2014. The curve of the epidemic is a classical exponential rise. This up to the mid-December 2014. This shows the distribution of cases, and a number of organizations were able to provide assistance to the national governments. As we know, Guinea, Sierra Leone, Liberia were principally affected. And among the organizations were included the Red Cross, Doctors Without Borders, UK Development, Oxfam, and CDC Atlanta. So I worked for a 6-week period with MSF, Doctors Without Borders, in the border area and the community of Foya. That community was just across a small river from Gekadu, where the outbreak began. And the dimensions, of course, are multiple in such an outbreak. Case management, outreach for health promotion, education, and contact tracing to try to control the epidemic, control the transmission. So this, for MSF, they were certainly looking for physicians and nurses and technicians who had experience with Ebola. But of course, up till that time, relatively few clinicians in the world had experience with Ebola. So they were happy to welcome all clinicians and provide an intensive brief training of about a week on the principles of protection and control. Many physicians who had not previously volunteered did so on this occasion. And it would be an opportunity for some of you folks in the room to undertake that kind of intense but short contribution most missions were 4 to 6 weeks under this circumstance. So as a result of that experience in this community of northern Liberia, the outbreak came under control quite quickly. You see on the top, and it's admittedly small, in the red were confirmed cases, in the green non-cases. You don't see there too many probable, but you can see the outbreak began in March and really accelerated in July of 2014. The next graph down is community death. That's people who died under suspicious circumstances. In many of those, a buccal swab was taken for a PCR, and Ebola was confirmed. That's the red. So you see the rise and relatively rapid fall. The green here is non-cases. So you looking at the red, you see a relatively good control. And we use the data here to do a statistical modeling of the course of the epidemic. So colleagues, led by colleagues at the London School of Hygiene, Sebastian Funk and John Edmonds, and their team, together with MSF and the local clinicians in Liberia, we put together the chronology, the epidemiology, and did modeling. And you can see here, the green represents the health promotion community activities of the program. But in actual fact, you might say, well, that times pretty well, but the decline in cases was already occurring before the intensive community education. And indeed, this shows the delay in coming to hospital. In the early phase, patients were coming only after 3 or 4 days of symptoms, whereas toward the end, they were coming within a day of symptoms, which suggests increased awareness and behavior change. So putting that together, we were able to model what was the effect of these interventions. And we see here in the red line the actual course of the epidemic. The scale is quite a bit smaller here. The course of the epidemic is there. If there had been no expansion to the bed capacity of the treatment facility, then we see projected what the course numbers would have been. So you see several hundred more cases. On the right-hand side, if there had been no change in behavior as a result of the community intervention and education, what the course might have been. And so you see, too, a comparable effect. So in the end, we felt that about 50% of the intervention success was due to provision of care, and by that, isolation of the cases, and the remainder due to changing community behavior. So there we are. Thank you very much. I would, in summary, just note that social accountability is becoming an increasingly prominent part of medical education and medical profession. It really is foundational to our ethical standards. There's growing recognition of it, and we as medical professionals can really contribute in a diversity of ways, from education, research, and service. So I would encourage you to consider this and to encounter some of the dilemmas that are faced. Thank you very much.